Nearly half of American adults have high blood pressure, but most couldn't tell you what those numbers actually mean. The CDC estimates that approximately 48% of US adults, about 120 million people, have hypertension using the 130/80 definition. Even more concerning, only about 1 in 4 adults with hypertension have it adequately controlled. Most people know their blood pressure is high, but very few understand why and how that affects their health, and that makes it much harder to improve. Hi, I'm Alex. I'm your nurse, and I have spent years helping people to manage, understand, and improve their blood pressure and therefore better take care of their heart and their health. The CDC estimates that nearly 1 in 3 adults with hypertension don't even know that they have it. Your blood pressure is a measure of how hard your heart is pumping and how much resistance it meets in order to do its job. Understanding those numbers can really influence your health and also help to highlight other issues that are occurring in other bodily systems. Having high blood pressure doesn't just affect your heart, it affects your eyesight, your kidneys, your brain, just to name a few systems. So let's break all of this down. How does the heart work? What do these numbers mean? So that we can understand more about your blood pressure and what it means to have hypertension. So, why do we even have blood pressure? Blood pressure exists because every cell in your body requires oxygen and nutrients. The heart pumps blood to deliver oxygen, glucose, hormones, nutrients, immune cells. Without adequate pressure, blood cannot reach all these different organ systems. So the brain, the kidneys, the eyes, your muscles. Blood pressure isn't bad. You literally cannot live without it. The goal isn't low blood pressure, it's an appropriate blood pressure. So we're going to talk about what these numbers mean, and we're going to talk about some appropriate parameters. But first, we're going to talk about how the heart works so that we can understand what these numbers are actually telling us. Okay, let's talk about the basics of how the heart works so that we can then understand our blood pressure. So your heart muscle is very contractile. The heart is a muscular pump composed of specialized cardiac muscle called myocardium. Unlike skeletal muscle, cardiac muscle contracts involuntarily about 100,000 times every day. The average heart pumps approximately 7,500 liters, which is about 2,000 gallons of blood daily. And so the heart is broken up into 4 main components. Or chambers. It's the atria and the ventricles. So the atria are the 2 smaller chambers at the top, and the ventricles are the 2 larger chambers at the bottom. So it'll start, your right atrium receives oxygen poor or deficient blood returning from the body. So this blood is coming from the body. The body has already used the oxygen. It's going back into the heart and it's going into the right atrium. From there, the atrium is going to pump it into the ventricle. And from there, the ventricle is going to pump it into the lungs. And that's where it's going to get oxygenated. So after the blood goes into the lungs and it gets oxygenated in the lungs, it's going to get pumped back into the other side of the heart. So the oxygenated blood goes into the left atrium, and that atrium receives this oxygen-rich blood and pumps it into the left ventricle. That then pumps the oxygenated blood throughout the rest of the body, okay? So the left ventricle is the thickest out of all of these ventricles, atrium, all these chambers. It has the thickest muscular wall because it must generate enough pressure to circulate blood throughout your entire body. So it's having to not only pump all of this fluid consistently, but also adjust and meet against the resistance and pressure that is within your body naturally. So this is why diseases affecting the left ventricle often have the greatest impact on your blood pressure. And we'll talk a little bit more about those later. I also wanted to discuss valves. Valves are in between to help the blood flow. So you've got the 4 ventricles, the 4 chambers, the 4 chambers. There's valves in between them to help pump that blood through, but also to help stop. We don't want the blood to backflow, right? We want everything to flow in one direction because if it backflows, then we have an increased risk of clots. So the four valves are mitral, tricuspid, aortic, and pulmonary. But essentially, the purpose is just to ensure one-way blood flow. And this prevents blood from flowing backwards after each contraction. So this is why when you have arrhythmias, which is an abnormal heart rhythm, that can be so problematic because it can increase the risk of backflow from the ventricles, or well, yeah, from the ventricles, but from the valves, because things are not flowing and pumping effectively through, so it could risk the backflow. Talking about vessels, there are arteries, veins, and capillaries. So your arteries carry oxygenated blood away from the heart. They're thicker muscular walls, and they are built to withstand very high pressure. Okay, so they're typically a little bit deeper, a little bit more internal, but this is why you don't want to hit an artery as opposed to a vein in a certain circumstance, because then you're going to be losing oxygenated blood, and it's going to be much more detrimental much more quickly. So then the difference with veins, these return deoxygenated blood that the body has already used back to the heart. So there's much lower pressure system in the veins and in the vascular system. So these contain valves as well, because we want to help move the blood throughout the body upward against gravity and against all the different pressure systems. So the valves help to pump the blood. Capillaries are another one. Tiny vessels, these are only 1 cell thick, and this is where oxygen and nutrients actually leave the bloodstream and enter into the tissue. So it's helpful for that oxygen exchange. And these are very, very small. So, talking about pressure in the heart, blood pressure depends on 2 major things: cardiac output and peripheral vascular resistance, or PVR. So, cardiac output, this is how much blood the heart pumps each minute. There's an equation. Cardiac output is equal to your heart rate times your stroke volume. So if cardiac output increases, blood pressure tends to increase as well. So essentially, it's how much your heart is pumping, how much fluid your heart is pumping, but we calculate that based on what your heart rate is, based on the actual amount that's being pumped in each stroke volume or contraction, if that makes sense. Essentially, just know that the cardiac output is how much blood the heart is pumping each minute. So moving into PVR, or peripheral vascular resistance, this is how tight or relaxed the arteries themselves actually are. So think of it like a garden hose. If you had a really wide hose, the water would flow really easily. But if the hose gets narrower, then the pressure increases and it gets harder to push it through. So when arteries constrict, the heart must pump much harder. So this increases the strain on the heart and therefore the blood pressure. So your heart is the pump, your arteries are the plumbing. So how does this affect our blood pressure reading? So the systolic is the top number, and then the diastolic is the bottom number. So this is 120/80, as we all know, is the normal. So this is, for systolic, the top number, it's the pressure inside arteries while the left ventricle is contracting. So the 120 is the top number. This means that the highest pressure produced during each heartbeat, okay, because it's coming from that left ventricle. The diastolic meaning is that's the bottom number. This is pressure remaining in the heart while it relaxes and is filling back up. This means that your arteries still maintain pressure even between heartbeats. And this is important because organs still need blood flow while the heart is relaxing. So a normal reading is roughly 120/80. The average reading for hypertension is 130 to 139/89 to 9, or 80 to 89 is technically higher. So 120/80 is like the gold standard, but I always like to say, just because I say normal doesn't mean that if your blood pressure is a little bit lower or higher at your baseline, that you are unhealthy or abnormal. It's just to give us as clinicians a parameter to know what we're working with, but ultimately you do want to be close to that range. So for me, my blood pressure normally sits on average 100 something over 60 something. That's my normal. So if I'm 130 over 80, that's technically within a healthy range, but for me, that would be hypertensive. That's kind of high. And so this is all subjective to each person. So we don't want somebody sitting at a hypotensive blood pressure, which would be 80 over 40. But again, if your blood pressure is sitting within a range, even if it's on a slightly lower, slightly higher side, it's just to know where is the baseline so that we can have an idea of where you're actually sitting. And another thing that's really important too is just because you have a lower blood pressure, if you are asymptomatic, meaning you don't have symptoms, then you're probably fine. That's probably your baseline. But when we start to have these vital sign changes and other symptoms, that's our body telling us that the numbers that it's showing us are concerning and it's something to pay attention to. So, hypertensive is roughly, we'll say 140 over 100. There's different stages to this, but ultimately, just for easy figures, normal 120 over 80, hypertensive 140 over 100. But then beyond that, hypertensive crisis would be 180 over roughly 120. And this requires immediate medical evaluation, especially if it's accompanied by symptoms such as chest pain, shortness of breath, severe headache, vision changes in particular, dizziness, weakness, difficulty speaking. Very high blood pressure can overwhelm the body's ability to compensate, and that's why these symptoms are coming up. So these suggest possible acute organ damage, not simply elevated blood pressure by itself, okay? That needs evaluation. So, hypertension isn't usually dangerous just because of one reading. It's dangerous because of thousands of extra heartbeats every day pushing against your arteries. Remember, your heart beats about 100,000 times per day. At a normal blood pressure, your arteries are built to handle that workload. When the pressure is chronically elevated, though, every heartbeat places a little more mechanical stress on the vessel walls. Over years, that cumulative stress can build up and it can contribute to atherosclerosis, which is plaque buildup in your vessels, arterial stiffening, which means they're not going to contract and flow as well, increased risk of heart attack, enlargement of the heart, particularly with the left ventricle, like we talked about, vision loss, chronic kidney disease. It's not one high blood pressure reading that can cause damage. It's millions of heartbeats over months and years working against the higher pressure. And essentially, it just wears down over time. Why might someone have hypertension? The vast majority of hypertension cases are primary hypertension, meaning there is no single identifiable cause. It develops over years through a combination of genetics, aging, lifestyle factors, and only about 5 to 10% of hypertension cases are secondary hypertension caused by another medical condition, such as kidney disease, or maybe sleep apnea, or maybe medications. So, what are modifiable risk factors and non-modifiable risk factors? Meaning, what can we work to fix and adjust if we have hypertension, and what is just going to be the way that it is? So, modifiable would be obesity, would be one that would cause hypertension. So, extra adipose tissue increases metabolic demand. The heart must pump blood to more tissue. Obesity is also associated with increased inflammation, insulin resistance, increased sympathetic nervous system activity, lots of different things that all contribute to higher blood pressure. Poor diet is another modifiable risk factor, particularly with a high sodium intake. Excess sodium promotes water retention, so more fluid inside the blood vessels means higher blood volume, which means higher blood pressure. So salt sensitivity varies among individuals, but reducing sodium intake generally lowers blood pressure, especially in people with hypertension. That's not necessarily to say that having a higher sodium intake is going to cause it. That would be a little bit more situational. Limited activity, this kind of comes back to obesity a little bit, but limited activity on its own can contribute to hypertension. So regular aerobic exercise improves your vascular function, the nitric oxide production, which which helps with contractions, and then arterial flexibility as well. So exercise can lower systolic blood pressure by approximately 5 to 10 milligrams per mercury in many individuals with hypertension. So let's say you're 120 over 80, which is great, but then you're going to naturally sit a little bit lower if you increase your activity because your heart is pumping more effectively because it's getting that exercise. Smoking is another modifiable risk factor. Nicotine causes immediate vasoconstriction, meaning that it causes the blood vessels to constrict and to narrow. So your heart rate will increase from there, and then your blood pressure will rise. Long-term smoking also damages the endothelium, or the inner lining of the blood vessels, and accelerates that atherosclerosis, or the plaque buildup in the vessels as well. Heavy alcohol intake can increase your stroke risk, your blood pressure, and your sympathetic nervous system activity. Reducing excessive alcohol consumption can meaningfully lower your blood pressure. And then chronic stress. Stress doesn't usually cause chronic hypertension by itself, but repeated activation of the sympathetic nervous system can elevate cortisol and then therefore contribute to persistently higher blood pressure. So people in high stress environments, lawyers, doctors, first responders, if they're constantly having, or even people in other careers are constantly having this higher activation, your pressure is just going to sit at that higher number at a baseline. And again, that's going to wear things down over time. So the non-modifiable risk factors are increased aging. So as you get older, your heart's just going to wear down a little bit. We want to keep that healthy. We want to keep that functioning appropriately, but it's not uncommon that sometimes hypertension can develop with older age, particularly in females post-menopause. Family history, sometimes we just have a predisposition in our family history, and it's just kind of the luck of the draw, which is not really luck, but it's non-modifiable, meaning we can't really do much about it to change it, but we can do things to try to help avoid the higher risk factors. And then postmenopausal women, as I stated, but also African American ancestry. They have a higher prevalence and earlier onset, typically in the US, of hypertension. So, how does hypertension affect other health systems? I mentioned kidneys, eyesight, the brain. We're going to talk about these. High pressure doesn't just stress the heart, it stresses every artery in the body and can therefore reach every organ. So the kidneys are a big one. People with really high blood pressure, and it's kind of a feedback in a way, people with really high blood pressure often have poorer kidney function, and people with poorer kidney function often have higher blood pressure because of the fluid balance and distribution and the pressure between the two. So kidneys contain millions of tiny filtering units called glomeruli. High pressure damages these delicate capillaries. So over years, the filtration declines and becomes less efficient. So this can lead to chronic kidney disease, protein in the urine, kidney failure, even if it gets too far gone. So hypertension is one of the leading causes of kidney failure worldwide, and it's one of the biggest reasons why it's so important to try to maintain some control over your blood pressure. Eyesight is another one. Your retina contains tiny arteries. Persistent hypertension can damage these vessels, causing hypertensive retinopathy, which could include effects such as blurred vision, vision loss, or retinal bleeding. And these are all really concerning side effects. But essentially, the idea is that because your heart is having to pump with so much extra pressure, it's increasing the pressure in your body and therefore in those other vessels. And because these vessels are so much smaller, they can rupture, it can cause changes in your eyesight. And that also pairs nicely with stroke risk and in your brain, how hypertension affects your brain. High pressure damages cerebral blood vessels. Your brain is covered in all kinds of capillaries and blood vessels because it uses so much oxygen and so much blood. It's what literally keeps you functioning and pumping or living. So Having adequate blood flow, having adequate oxygenation is really important. But again, if this is having to work so hard, your heart is having to work so hard and it's pumping so much, it's going to increase the pressure in your brain. So this increases the risk of ischemic stroke, hemorrhagic stroke, vascular dementia, things like that. Hypertension is the single most important modifiable risk factor for a stroke. So if you have high risk for stroke and you have high blood pressure, trying to control your blood pressure will hopefully help to try to control your risk for stroke. So the heart must continually pump against increased resistance. The left ventricle gradually becomes thicker. Left ventricle hypertrophy is what this is called. So initially this helps because that muscle becomes stronger, but then it actually kind of weakens and wears down. So eventually the thickened heart becomes stiff, leading to poorer filling and potentially even heart failure. And so this is not just in general with everybody aging. This is those with high blood pressure, chronic hypertension. It can actually affect your heart more long term, as well as these other bodily systems. So, one thing that I wanted to talk about was, can you actually feel high blood pressure? One of the biggest misconceptions in healthcare is that you'll know when your blood pressure is high. The truth is, you usually won't. Many people believe they'll know when their blood pressure is elevated because of headaches or feeling flushed, but that's not really the case. In reality, hypertension is often called the silent killer because most people have no symptoms until significant damage has already occurred. High blood pressure usually develops gradually over years. As the pressure slowly increases, your body adapts. So, because of this, most people have no symptoms even when their blood pressure is significantly elevated. So, most people discover that they have hypertension only because they found it out during a routine physical, or they did a random check at home, or they developed complications that we talked about, such as a stroke or kidney disease or changes in their eyesight. Most people with chronic hypertension do not experience headaches, dizziness, facial flushing, or nosebleeds only because their blood pressure is elevated. While these symptoms can occur for many reasons, there are not reliable indicators of routine high blood pressure. Research shows that mild to moderate hypertension is generally asymptomatic, hence why it's called a silent killer. Your body doesn't have a pressure sensor that tells you, hey, your blood pressure is 155 over 100 today. Blood vessels themselves don't contain pain receptors that detect pressure in the way that your skin would maybe detect pain. So instead, the body responds by thickening those vessel walls, remodeling the vessels, and adjusting the pressure to a higher rate over time. Unfortunately, while the body adapts, damage continues silently. So that's why someone can feel completely normal while years of uncontrolled hypertension gradually injure their brain, their heart, their kidneys, their eyes, and their blood vessels overall. Think of it like driving with slightly overinflated tires. The car still drives normally, but over thousands of miles, the extra pressure causes wear and tear that you can't actually see. So, what are my nursing tips for managing and improving your blood pressure? Daily activity, I always advocate for. 150 minutes weekly of moderate aerobic activity. Resistance training, 30 minutes at least for 2 to 3 sessions weekly. So I always advocate for walking because it is so easy, but I would say at least 30 minutes per day of exercise, but honestly, ideally an hour. And this is not going and killing yourself at the gym. This is just making sure that you get up and get walks consistently throughout the day and you're not being sedentary all the time, or going and getting a workout several times a week and then doing another activity that you enjoy for the other days, but just getting some kind of physical activity, even if it's not some massive weight training or HIIT session, doing something every day. Diet choices are a big one for hypertension. The DASH diet is one of the most studied diets for hypertension. So this emphasizes fruits, vegetables, beans, whole grains, lean proteins, and low-fat dairy. This reduces your saturated fat, your processed foods, but most importantly, the sodium. So This can lower systolic blood pressure by approximately 8 to 14 milligrams per mercury in some individuals. So the general recommendation for sodium is going to be to aim for less than 2,300 milligrams per day, and ideally around 1,500 milligrams per day for many adults with hypertension, if feasible. So then pairing that diet and exercise with pairing together the diet and exercise, weight loss can help lower blood pressure, particularly for those that are significantly overweight. Your body is going to have much more pressure, much more work that it is having to do to pump. The heart is going to have more work with which to pump. If you are larger, your heart is going to have to work harder. It's just the reality. So even modest weight loss can lower the blood pressure. So a common estimate is about 1 milligram per mercury of reduction in systolic blood pressure per kilogram of weight loss, though this can vary and be subjective for each person. So about 2 pounds can reduce your systolic blood pressure by about 1 point, is the translation there. Sleep. Poor sleep and untreated obstructive sleep apnea are strongly associated with hypertension. If someone snores heavily, wakes up gasping, and has excessive daytime sleepiness, evaluation for sleep apnea may be appropriate. It's meaning that you're not getting enough sleep at night and you're not getting enough oxygen while you're sleeping because you're not breathing. And that's kind of important to check. So because you're essentially, it's not holding your breath, but not breathing in, it increases the pressure. Another tip would be to quit smoking. I'm just going to leave that one there. There are other medications that you can take that would be prescribed by your provider. Should you have tried all of these options, or maybe you have non-modifiable risk factors that you're working against. So things like ACE inhibitors, calcium channel blockers, thiazide diuretics, and beta blockers are all things that can help to improve your blood pressure and your cardiac functioning for their different pharmacological properties. But I'm not going to get into all of that. But these are often prescribed for specific indications rather than a first-line therapy for uncomplicated hypertension alone. Okay, so that discuss with your doctor. Key takeaways for you today, though. Blood pressure isn't just a number on a machine. It's your body's way of telling you how hard your heart and blood vessels are working every second of every day. Understanding your blood pressure is an important consideration in understanding your health. Your blood pressure is a requirement for your body and your heart to pump and exist. So it's not a bad thing to have. We just want to make sure it's within a healthy range. I hope this helped. If it did, please consider liking and subscribing. It would help. If you have any questions, you can reach out to me. I'm on Instagram at Health Recoded Podcast, or you can find me in my email. I hope this helped. I will see you guys next week for our next topic.